Over to you, Dr. Mazeni.
Well, thanks, Shiva and chairpersons, Dr. Ananta, and the rest of the panelists. Thank you, Shiva, for this invitation. It's been a great session, although just online, but I've enjoyed the sessions that I've been involved in. And I'm going to present something which has been requested at the last minute. So I have not really prepared a typical life in the box, but I think the ETE and the angio images will do justice to this presentation. So my topic is presenting a case of Ceraflex, which I'm told is not really available in India yet. Yeah, but this is a patient who is 49 years old. Can you see my screen?
Yes, Dr. Mazeni, very well.
Okay, all right. Okay, so she is 57 kg, weighing 57 kg, who has recently become more symptomatic or mildly symptomatic. In the past, she has refused treatment and on and off came and did not come to the clinic follow-up. But she is otherwise well, and the main clinical findings is the soft ejection systolic murmur, typical of an ASD, and she has mild cardiomegaly, and the second heart sound is not loud. And this is an X-ray showing that she has a fairly moderate cardiomegaly, and the RA border is enlarged, and we can see that the pulmonary arteries are increased in size also in terms of plethoric lung fills. Her ECG is typical of someone with a secondary ASD of significant flow, and there were no arrhythmias. This is a transthoracic echo just before the procedure, and this was done about 3 weeks ago. And from this still picture, you can see how big the RA and the RB are, and this is the squashed left atrium. And on this moving picture of color Doppler and 2D, we can see that apart from the large right heart chambers, we can see that there is a fairly decent big-sized ASD with a left-right shunt. The TR in this plane is difficult to see. And this is TEE at the time, just before the procedure. In the 0 degrees, we can see that this is the fairly moderately large ASD and very well covered posterior rim and the typical deficiency of the aortic rim, which is better seen on the 45-degree view. And the rims towards the defect has become quite thin. And on this, the defect measures 25 millimeters in diameter. And this is the view on 45 degrees and 0 degrees that showed a 25 mm measurement of the diameter, and slightly smaller on this 45-degree view, a 23 mm defect size. Nice picture of the bicable view showing good rims both inferiorly and superiorly. And here the defect measures 25 millimeters. It's fairly nice central defect for doing something which is fairly new, using a new device. So at Kath, she has good hemodynamics. The PA pressure is just mildly elevated with good normal saturation. QPQS is close to 3:1 with a normal PVRI. And I'm just going to mention a bit about what the device is. And as the other devices that are nitinol based, and this is a self-expandable double disc device. Sorry, I need to go back. Yeah, okay. And with instead of Dacron, the PET membranes sewn to each disc. What I want to mention are the specific features of this compared to the others. That like Cocoon, it is covered with a coating, but not like Cocoon, which is platinum, but this is a ceramic coating with titanium nitride. And what the manufacturers consider as advantages are, these are still something that has not been proven by studies, but it is supposed to reduce thrombus formation, promotes a faster endothelialization, and improves biocompatibility like Cocoon, which reduces a lot in terms of nickel leaching into the bloodstream post-implantation. And the other thing is that the coating is supposed to soften the nitinol wires and thus making it a softer device. Again, there is no bench testing with regards to this comparing to the other non-coated device, but by the feel of it, it does feel softer, and this might have a safety advantage with regards to possible risk of erosion, probably. And also the other thing is that this is something that it shares with the Occlutech device in the sense that the LA disc, there is no hub where the wires ends are clamped, and therefore this additional feature might reduce the risk of thrombus formation on the LA disc. And this is another important feature of the device, which is the delivery sheath. Oh, yeah, okay. So what is unusual or what is special about this delivery device is that it is pre-mounted, and number two is the flexibility of the connection between the cable and the disc and the device. It is held to the cable by a 19-L wire, which forms a loop, and this is locked. And the short video shows how, when we are happy with the position, how to release the lock and therefore release the device. And I'll just play it because this gives a 360-degree flexibility rotation of the cable around the device and gives us a position. What we see before release is what we get after release. So we don't have that kind of jump or recoil of the device once it is off the cable that we see with the typical screw-on cable onto the device. I suppose this adds quite significantly in terms of precision of placement, and without that final jump or recoil that might give us a bit of a scare whether the device is going to plop out of the defect and into the left atrium. So I'll just play the short video and showing how it is released. We have the two buttons, the orange and the blue button. Pressing down the orange button will enable us to unlock, which is done by pulling the blue device backwards, and that will release this wire that is holding the device to the cable and therefore releasing the device. Very short one. Sorry, I'm going to start from start. Okay. Okay, and this is what it appears. Usually when you have this kind of attachment by the screw of the cable onto the device, we can see that it is perpendicular to the disc, whereas here with the Ceraflex, once it is deployed, the cable is more or less parallel to the disc, and this is how the device will appear, and there will be no jump and no recoil once it is unlocked and released from the cable. And this is before release, and this is after release. So this is not the particular patient. I'm just showing how it looks like. This is a different patient, and this is once both discs has been deployed, and this is how it sits. We are pushing up and down. At this point, the cable is still attached to the device, and here the cable has been released, freed from the device, and we can see that there is no jump at all when the device is released from the cable. So going back to this particular patient, with the 25mm diameter defect, we used a 30mm device, which was deployed using a 12/12 French sheath. And this is the LA disc is brought towards the septum, towards the defect. Here, showing that device on fluoroscopy, you can see that there is no hub on the LA disc, and the device is now, the LA disc is now deployed, and this is brought towards the defect, and this is how the device sits once both discs are open. And this is how it's going to look like at deployment and after deployment. So this is the particular patient that I had presented the clinical data earlier. Again, we normally like to see pull up and down to see how the device sits, and we are quite happy that this is how it should be sitting, and confirming that with the echocardiogram. And again, when we detach the wire loop from the device, we can see that there is no jump or there's no recoil of the device as we would normally see with the screw-on cable. And here the cable is almost parallel to the disc of the right atrium. So this is the immediate post-implantation, showing that the disc has flattened out very nicely, and the two ends wrapping around the aortic root as shown here. And this is the kind of view that we would normally like to see post-device implantation. And on the bicaval view, again, showing very nice position of the device with still a bit of flow through the device fabric. And this is before discharge the following day, again, showing a nice position of the device. And this is on the left X-ray, showing the device which wraps around the aortic root. So my take on the device, I like a lot the 360 flexibility that the cable has in relation to the device, and that we don't see any recoil or jump at the point of release. This is not a big deal in general, but I think sometimes when we are not sure, then we might be worried whether the device is going to be a bit, in terms of its position, a bit distorted or not like what we wanted to see at the start. And probably this might have special benefit when we are closing, for example, in an ASD with malaligned septum. I don't know, but I think if we do have such a case, we would probably use this device to close such a difficult ASD as has been presented earlier by Dr. Harimurthy. And number two, the softer device that is attributed to the ceramic coating, perhaps it might have safety advantage in terms of the long-term treated complication of erosions, but still we don't have enough data to support that. But on the other hand, the softness of the device may make it a bit longer, require a bit longer for the device to fully reconfigure after deployment, which means having the two discs completely flat. But again, this is something that is seen in a few cases, and in general, the device did configure to what is its shape as expected. And the other thing that I have something of view that might be a problem is that the absence of a screw hub, because this the cable holds the device by using a wire loop without a screw hub. And this, in the case of, for example, embolization or migration of device, without that, it might be difficult to retrieve the device. I suppose this is hopefully not something which is common, but if it does occur, this might be something that we will hope that there is something that can be modified to enable us to retrieve the device without sending the patient to surgery. So with that, I would like to thank the organizers, especially my friend Dr. Shiva Kumar, for inviting me again to this wonderful PCSI symposium. Thank you for your attention.
Thanks, Mazeni. It's a wonderful presentation. Actually, we don't have an access to this device as of today, but we may get it soon. Now, for a very old generation person, we do have a practice of doing a soft Minnesota wiggle with a pull and push at the end of deploying the device before we unscrew. So in this particular device, is it all possible?
To do that? Yes, Siva, I still do it for this device. Although I think it is probably, the need for that is probably not as marked as before. But even in normal the other devices, many people don't do that anymore. I think this is something that is a practice that was carried over. Like people like you and me will keep doing this, but it may not have that kind of value, especially for this device, I think.
The other chairperson, Dr. Balaganesh, any questions to Dr. Mazeni?